Very excited on this Infinity Podcast TAMC special, TAMC 2025 special, to introduce another true legend of aesthetic medicine. And I'm very honored because we have some of the biggest names that have ever walked to this earth and who are kind of plying the trade in our business of aesthetic medicine. And this guy was an actor once upon a time, Michael Kane. He's now decided to be a surgeon and aesthetic. No, I'm joking. I'd like to introduce Michael Kane, one of the best aesthetic doctors in the world, right?
Thanks, very kind of you. And I'm a little bit shorter, my hair's a little straighter than the other Michael Kane.
But you're younger than the other Michael Kane.
I am.
I gather you want to be great friends with Doris Day as well.
Yes, well, way back in the day, Allergan thought it was sort of funny to make a little Hollywood table. So they always had Michael Kane and Doris Day sitting next to each other, and we became very good friends, but that's how it started.
Great. You say that's how it started. Could you tell me about your beginnings? What are your kind of roots, and how did you get into aesthetic medicine? Or aesthetic surgery?
Well, my roots, my mother was mostly Albanian and a little Greek, so sort of the neighborhood here. Father was mostly Irish and a little Welsh. And I got into aesthetic medicine. I just saw this gentleman, by the way, last week. I was doing a facelift at Manhattan Eye Ear Throat, and Richard Listman is like the king of oculoplastic surgery in New York. And he's talking to me in the residence lounge one day, and he said, have you ever heard of this botulism stuff that people are injecting for strabismus and blepharospasm? And I say, no. And I say, well, how long does it work for? And I think he's going to tell me 2 or 3 days. And he says, about 3 months. And the next thing I said was, well, what about the corrugators and the frontalis and the crow's feet? And maybe 20 seconds later, I said, well, what about the DAO and platysma? Why not relax the things pulling your face down? Why let those muscles help gravity pull your face to the floor? And that was in July of 1991. Well, I wasn't even in practice yet. I was still a fellow. So I had to go through the process. I had to talk to my program director, then the current department chairman, but he was leaving at the end of the year, the legend Tom Rees. Tom Rees with Tom Baker, is one of the co-founders of the Aesthetic Society, formerly the American Society of Aesthetic Plastic Surgery. And Tom Rees got it right away. He said, this could be a really big thing. And I said, well, if it works, it's going to make brow lifts go away, which I think is a good thing. I think most surgical brow lifts don't look so good, and you don't really have tremendous control over the brows. And that was the start of it for me, and just been rolling ever since.
Yeah, I mean, you are one of the best-known botulinum toxinum doctors in the world, right? You've been in a lot of research papers, and in fact, at TAMC Congress, you often give us some amazing talks on Botox.
And about 4 days ago, I did a little meeting with my friend Jean Carruthers.
Oh, you did?
Yeah. It's always nice to see Jeannie.
The woman who started it all, really.
Yeah.
With that, Botox is what really started the whole field of aesthetic medicine. That was the first treatment, wasn't it?
But way back then, it wasn't even Botox yet. It was still Oculinum when I started playing around with it. Yeah.
Where do you think Botox is now? In fact, at TAMC Congress this year, I have to do a talk of the future. I think there's this whole section of the future filler, the future laser, the future toxin. I am going to talk about the future toxin. I even thought about what if it lasted forever, but you had an antidote to then reverse the action. That could be quite fun. So where do you think toxins are now and where they were in 91?
Well, I think in a perfect world, you would get a tox that lasted a little bit longer. Not a lot longer. I don't think you would want a permanent tox or something that lasted 10 years or so, because things change as we age. Even if your injection were perfect, what that perfect injection would be in 10 years is not the same as it would be now. And I think in a perfect world, you would have very good targeting with that, besides the manual targeting that you're doing with a needle and where you're squirting the juice. It's the juice being able to stick where you want it. I think that would be great.
Would AI help us with this in any way?
I don't think so. And it's interesting.
Good answer.
I was asked, and it'll probably be the last time I'm ever asked to do a meeting that was very heavy on AI. And towards the end of the day, I stood up and said, well, that's all well and good, but they're is no AI. Turing originally wrote the rules for what is AI, and you always have to go down to definitions because people always dumb things down for the sake of marketing. Yeah. And I use nanotechnology as the perfect example. Richard Feynman first described nanotechnology, I think, in 1959. And we still don't have nanotechnology. The definition of nanotechnology is a 5-atom machine that does something. We don't have any 5-atom machines. And nanotechnology is almost passé. People started to use it commercially because it sounded cool, it sounded scientific for anything that was small, even though that's not what it means. And when I look at AI, not only do our current AIs not pass the Turing test, which is the sort of definition of what an AI is, but the other person big in AI is Ray Kurzweil. And if you ever want to have fun, I read his short little 900-page book, The Singularity is Near, where he talks about AI. And it's clear that the singularity, which would be the birth of AI, has not happened. What we have are much faster, much better programs. So the marketers decided to call them AI. They're not AI, but they're great programs. They're really fast. And then, someone could argue with me that, well, machine learning is sort of AI, and I would disagree. When I wrote my first book in 2002, I'm not a very good typist. I'm a hunt and peck typist. So when I decided to write that book and I had a contract and I was under a lot of pressure to get a book out quickly, I bought a new laptop and a voice dictation program, right? So I would say something and the words would come out. Guess who made and wrote that program? Ray Kurzweil, the other AI king. Yeah. And what I did, you had a chapter in a book to read. So the computer knew what the chapter was, and then I read it. And so that was learning. Yeah. And that's 23 years ago. 23 years ago, people weren't calling machine learning AI. And so I'm still a little skeptical. I'm not skeptical about AI. It'll be here eventually, but when it happens, it'll be a big deal. Everyone will notice.
Michael, that's really interesting because you're absolutely right. Everyone's jumping on this bandwagon that AI is already here and people are asking the AI for everything. It's just the faster Google in a way. It's not autonomous. It can help us even in research because it's a faster program. So it can help us in research to find new solutions. But you're right. It's not.
But it's not conscious. Yeah. It's not a sentient being.
Thank you for that. I reckon this podcast and what you just said will be one of the most popular podcasts we'll record. People will listen to that. But let's get back to aesthetic medicine. Right. And I know you've got a lecture at the Congress this year about G prime. That question of G prime, I even in a podcast earlier on talked about when I was younger, we were injecting glabellas with needle. And the advice was, you'll be all right if you use a lower G prime. You won't get a vascular compromise. This is 20-something years ago. Tell us a little bit about G prime.
Well, as you said, you cannot go to a Congress and you cannot sit through a filler meeting without hearing G prime about a dozen times. I think G prime is mostly nonsense, right? What we're basically talking about is the stiffness or robustness of a filler. But that doesn't sound smart enough. So docs don't like saying that. They like to sound fancy. They like to sound sort of a standard deviation in intelligence away from their patients. So they don't say, well, this filler is kind of soft and this filler is kind of stiff. I do to my patients. They say, oh, well, the G prime and the G double prime and the elastic modulus, and they think it makes them sound smart. I think it does exactly the opposite. And when you look at G prime, there's G prime, and there was one article that started all this about 15 years ago. It was around for a while, but that really got the G prime ball rolling. And they have a list of all of these things from high G prime to low G prime. They say high G prime things are really good for lifting. Now, I don't think any goo is good for lifting. Lifting, going back to AI, implies that it's a sentient being, that it wants to hold things up. It does not. It's goo. It's lifeless. All it does is deform the soft tissues around it. Now, obviously, companies don't want to brag about their deformation coefficient, right? That's not very good marketing. So they use lifting instead, even though it's not really lifting. It depends where you put it. You can get a little lift if you put it on top of a bony surface and there's some lax soft tissue above it, but it's not by its very nature lifting. But even just talking about the G prime, all of these fillers out of the syringe are relatively anhydrous. That means they all want to suck up water. Do they suck up the same amount of water? They do not. Some suck up a lot of water, some suck up a little water, some in the middle range. Well, guess what happens? When they suck up water, that completely changes their G prime. So what is the point of measuring the G prime and an anhydrous filler not in your body, not equilibrated with water, when we know that when it does equilibrate, the G prime is going to be totally different. In fact, in this paper, the product with the highest G prime was Radiesse. So they talk about how that's the product to use. And I'm not saying anything good or bad about Radiesse. And then, because they had the indication then, there's Radiesse with a little lidocaine added in.
And the hyperdiluted and stuff like that.
And guess what? All of a sudden, the G prime plummets down to the middle of the pack. So does that mean it's not a high G prime filler? Does that mean it's a medium G prime filler? You know,
why do we get
off that
delayed type onset hypersensitivity or swelling, especially it's often in the jawline, especially if it's a higher G prime? I don't need to mention a big company has a very high G prime filler, which we use a fanning technique. They used to teach the bolus technique, and I found quite a few hypersensitivity reactions to delayed type onset. Why is that happening? Is that anything to do with G prime or?
Probably not. What you're talking about probably has to do with very short chain HA. HA, hyaluronic acid, is in everybody. It's one of the most common things in your skin. In fact, when you're 20 years old, your skin is chock full of HA. And if you live to be 100, there's not too much HA. So I'm of the belief that not only can HA help you look better in the short term, I think it's actually good for your skin. Right? So I'm willing to go there. And I think that HA in its natural state is very long. They're long chains. We know that tiny fragmented HA are inflammatory fragments. So I think that what we're seeing there with some of the products are little short chains as the product is being degraded. That's why you don't get it right away. You get it months later. That's when it's degrading, and you have a few short chains, and I think that causes some inflammation.
Michael, a lot of pearls of wisdom in this podcast. Me as a seasoned aesthetic doctor, even I'm learning, which is amazing. So let's learn further. As you know, I do a lot of tear trough and eye bag treatments. I've done 20,000 in my life. You've probably done 50,000. It's a favorite area of mine. And even though I don't get a lot of lymphedema and edema, I do get it. And then fine, you handle it and you tell the patients what to do. But now there are even new tools, aren't there, on the market, which can help us combat that problem.
And I'll fully say I'm a little obsessed with lymphedema around the eyes, or malar edema. You know, there was this number that we always heard in medical school and residency, that if patients live long enough, about 30% of people will get some malar edema or periorbital edema. I think that's wrong. I think if you look closely enough, it's more like 80% of people. The lymphatic drainage of the orbit is very frail, and it's completely different from the rest of the face, which is why we tend to get edema around the eyes. Now, HA filler, which is commonly put around the eyes, and I do that every day, HA filler acts like a sponge, and that hangs onto and can magnify that edema, which is why I greatly prefer very, very, very tiny amounts of HA, and I do it fairly superficially. I know a lot of people don't like that. It's sort of a high-risk, high-reward way to do it. But the closer you are to the surface, the more effect you get with tiny amounts. The deeper you are, the more you have to put in. I don't want to put in a lot of HA because so many people have malar edema. But until now, all we could say was, well, maybe we'll dissolve your filler, or sleep with a few extra pillows under your head and shoulders,
Or some
avoid salt,
prednisolone or
all
something.
that stuff. But that does not help true malar edema people. And so I went to work on a formulation with a company, ABG Lab. I've been working with them for a little over 14 years now. And we have a product, and I talk about its mechanism of action, and it appears to help stop leakage of fluid through the blood vessels, through the capillaries, thereby decreasing the appearance of lymphedema. It can also help shrink the fat around the eyes. Now, in some patients, you see, it's probably a little bit of both. It's probably making lymphedema a little bit better and probably making the fat shrink a little bit. Patient doesn't care which it is. And the thing I like about it is that until that product was launched, we really didn't have anything for these people. There are millions and millions of people. I've sat at ASAPs, the plastic surgery societies. I've sat on panels all over the world talking about periorbital edema, and everyone just throws up their hands and says, sleep with your head elevated, avoid salt. There's one plastic surgeon in Turkey who actually chops out some skin in the lower lid, but it leaves a scar coming right across here where it is. But, eventually, sometimes these festoons or malar edema of such magnitude, patient is willing to trade a scar for that bump.
What is in this product? It's called MesoEye, right?
MesoEye C71. There are a few things. There's the hexapeptide 17, or the opioid peptide, which we know opens the microcirculation, which helps to drain fluid away. So that's good. There's also periorbital peptide, which in bench studies in the lab, we've shown if you culture endothelial cells, and endothelial cells, as you know, are the cells that are the inner layer of all blood vessels. And if you add interleukin-1 beta to that, it weakens the connection between these cells, and so fluid leaks out. Well, that's bad. That makes edema. Well, if you incubate it with periorbital peptide, not only does it negate the interleukin-1 beta effect, it actually stops and decreases the amount of flow of fluid through the blood vessel, even that hasn't been damaged by interleukin-1 beta. So on one hand, it stops the flow of liquid or edema out of the blood vessels and into the area around the eyes. And we think, in the other hand, it helps to open the microcirculation and helps to drain that edema around the eyes.
Amazing. And I think it's such an important tool to me as well. And now, because these podcasts can't last too long, some amazing science, some amazing pearls of wisdom there, Michael, as always. I always so enjoy you coming to TAMC. This is your what, fourth? Fourth
Yes.
time?
Yes.
You've always been a real soldier of this Congress. You've been such a great friend. And it's always such an honor to have you here. What are your expectations of TAMC 2025, our Infinity TAMC, because it's 8 put on the side. What are your expectations?
Well,
I think you've got a lot of work to do.
I
You've
like
got lots of lectures this
controversy,
time.
as you know.
You do.
I like to stir the pot. I like to see what people think, and I like to challenge people. I also like to challenge the conventional wisdom, which is so often wrong. Like, thank you. I remember you let me give what many people thought was a crazy, very long presentation about why people get droopy eyelids after Botox and things like Botox. And there are over 1,000 articles in the medical literature, peer-reviewed medical literature, that say the reason that happens is because toxin gets in the levator palpebrae muscle. And I believe I have proven that doesn't happen. So that's 1,000 articles that are out there.
That's amazing.
That
I look forward
probably
to-
should be retracted.
I look forward to your lectures. I look forward to having fun at the ABBA party and the gala dinner as well. And I hope you're going to keep coming to our Congress for many years to come. It's been a real pleasure, Michael. Thank you for coming. Guys, the legend that is Michael Kane. Not the actor. Thank you, Michael.
All right.
Thank you.
Thanks, Nick. It's a pleasure.
Thank you.